Greetings, everyone. Thank you for joining us today. My name is Melissa Begg, and I have the great honor of serving as Dean of the Columbia School of Social Work. It's my pleasure to welcome you to what promises to be a highly informative discussion on the remarkable Healing Communities Study, which aims to reduce opioid overdose and death in some of the hardest hit counties across 4 states by using proven, evidence-based, deeply community engaged strategies. I am both proud and grateful that this interdisciplinary study finds its home here in the School of Social Work, where our focus is and always has been on ensuring that everyone can reach their full potential, no matter their life circumstances. We're about to celebrate our 125th year as the first School of Social Work in the nation, and I'm so proud of the work my colleagues are doing. I like to say that social workers are helping solve some of the most pressing issues of our time, like the opioid crisis. They are uniquely trained in understanding how individuals function within their communities, and that recognition is absolutely central to the Healing Communities approach. This interdisciplinary, cross-sectoral, multi-site, community-engaged study brings together diverse constituents, many with lived experience, across New York and 3 other states, to build coalitions to combat the terrible toll of the opioid crisis on our nation. In today's session, we are delighted to host the Healing Communities Study's National Program Director, an accomplished scientist and remarkable leader, Dr. Redonna Chandler, from the National Institute on Drug Abuse at NIH. Dr. Chandler will discuss the progress and impact of this groundbreaking study and its potential to impact the entire country. And now I have the pleasure of introducing our moderator for today, Dr. Nabila El-Bassel. Dr. El-Bassel is the Wilma and Albert Musher Professor of Social Work, and she's also a university professor, the highest academic honor bestowed upon Columbia University faculty, and with good reason. In addition to leading the Healing Communities Study here in New York, she directs the Social Intervention Group and the Global Health Research Center of Central Asia. She also leads a brand new university center called Chosen. And Chosen draws on the expertise of faculty, researchers, and practitioners from across the university to develop and implement programs, policies, and practices that prevent and treat substance use disorders. Dr. El-Bassel is an incredibly productive scholar and an amazing mentor, having received the university's award for outstanding mentorship. She's one of our world's leading experts in intervention science, and I'm glad to call her my colleague. And I am so excited about what we're going to hear today, Nabila, from you and Dr. Chandler. So it's my pleasure to turn it over to you.
Thank you very much, Dean Begg, for your introduction and for all your support for the Healing Community Study. You have been very, very supportive, and you provided us at the school with all the resources we need to succeed in this huge study. So thank you very much. I also want to say that this event is co-sponsored by Chosen, the Columbia-wide Center for Healing on Opiate and other use of drugs. So now it is my great honor and pleasure to introduce Dr. Redonna Chandler. Dr. Redonna Chandler is currently the director of the Healing Community Study at the National Institute of Drug Abuse. It was her initiative that led the development of the RFA for the Healing Community Study, which is a massive community-based research undertaking in 4 states with multiple scientific components, which you'll hear and learn about it when she speaks. Dr. Chandler also directs the AIDS research program at NIDA, and in this role, she is responsible for the development, planning, and coordination of all high-priority research on HIV and AIDS and drug use within NIDA and across other NIH institutes. Dr. Chandler began her federal government career in 1996 at the Department of Justice, where she directed a number of innovative drug treatment initiatives and programs. In fact, she joined NIH in 2002, where she has served in several important capacities. From 2016 to 2018, Dr. Chandler was the Deputy Director for the Division of Clinical Innovation at the National Center for Advancing Translation Sciences, where she provided leadership to the clinical and translational science program. Dr. Chandler's expertise includes clinical trials among individuals involved in the criminal justice system, improving adherence to drug treatment and HIV care. She's expert in health services research and implementation science, and you'll see today her expertise on community-based research. Dr. Chandler has co-authored and authored numerous articles and book chapters, and it will take me really maybe an hour to be able to report to you what she has produced. But her research influenced and advanced both HIV and substance abuse research. One important piece I will really highlight is that Dr. Chandler is very committed to promoting the new generation of addiction and HIV scientists, and especially women and people of color. I observed that in her work, and I've seen it, and I met a lot of people where women and people of color that Dr. Chandler has promoted. Thank you for all what you have done, Dr. Chandler, and thank you for leading us with the Communities That Heal study. And today, Dr. Chandler is going to talk about this study, and her title of her presentation is Transforming the Current Situation of the Opioid Crisis with the Healing Community Study. Dr. Chandler will speak for 40 minutes and we'll have the last 10 minutes for question and answers. Dr. Chandler, the floor is yours.
Well, thank you, Nabila, so much for that very generous and gracious introduction. It's a pleasure to be here with you all this afternoon and to be able to spend a little bit of time talking about what has been my obsession, and I think probably the love of my professional life for the last 4 years, the Healing Community Study. And it's been a real pleasure to have Dr. El-Basal and all of her colleagues that she's brought together across the state of New York on this journey with this study. And I hope to give you a little bit of a sense today about the breadth of the study and some of the things we're learning and accomplishing. So the Healing Communities Study has a very ambitious goal, and that is to reduce overdose deaths by 40%. The original intent of the study focused intently on opioid overdose fatalities. However, as time has passed and the drug supply has changed, and the drug supply for stimulants and other types of drugs has been adulterated with fentanyl, which is an opioid itself, we've focused a little bit more on overdose fatalities overall and those that have some connection to the opioid crisis. We're testing the impact of an intervention that we call the Communities That Heal intervention, and I will refer to as CTH, and on not only overdose fatalities, but other outcomes in 67 highly impacted communities in 4 states, Kentucky, Massachusetts, New York, and Ohio. We're going to determine the cost and cost effectiveness of the intervention. And as a scientific study, the HCS has the most rigorous randomized clinical trial design. It is a multi-site, parallel arm, cluster randomized wait list control arm trial, which is a mouthful, which is to say that we took our 67 communities and we randomly assigned them to either receive the intervention initially, we call those wave 1 communities, or to be on a wait list and receive the intervention following wave 1 intervention in a comparison period of data collection, and we call those wave 2 communities. As I said, we're in 4 states, and here you can see the maps of the states that are involved in the study, as well as the communities that are included. Wave 1 communities are in orange. We completed our intervention period with them the end of June of last year in 2022, and began intervening in our wave 2 communities now. They're in the dark purple, and we'll finish up intervening with them in December of 2023. Here's a little bit on the baseline characteristics of the communities that are participating in the study as of 2019. One of the really impressive things about the study is the number of individuals that we touch. We touch over 10 million lives. That's because we're not assigning people to receive intervention. We're assigning entire communities and all of the people that exist within those particular communities. You can also see that at the time the study began, we had very high rates of opioid overdose fatalities. It was really important to us that we be developing solutions that would work in urban as well as in rural settings. And so when the funding opportunity announcement came out, people who were applying were required to come in with a certain proportion of their communities, rural as well as urban. So we've got some nice distribution there. And it just happened that all of the sites that had scientifically competitive applications were in Medicaid expansion states. So I'm going to talk about the Communities That Heal intervention and go into some depth on the 3 different components of the intervention, as well as present some very specific examples of ways that this intervention has come to life within the 4 states. The first really critical component of the intervention is the community engagement component. And I'll go through the phases of the community engagement intervention where we come in and really begin to introduce ourselves, meet people, and begin to work on the intervention. Next, I'll talk about the opioid overdose reduction continuum of care, or ORCA, which is our menu of evidence-based practices and implementation strategies. And then finally, we're very proud of a set of health communications campaigns that we've developed as a part of this intervention. And so I'll briefly talk about that as well. So let's start with the community engagement component. Community engagement is done in several different ways. First of all, each state formed a statewide community advisory board. And that's made up of key leaders within the state, but also people from the different communities that come together to provide some level of input and expertise and oversight as the study has moved forward. And then each community has its own community coalition, and those coalitions are comprised of members of key stakeholders from communities. In some instances, they are people that are part of the treatment system, healthcare providers, someone who's involved in the criminal legal system, behavioral health, but there are also people that are involved in other social support services, including housing. The business sector is represented in some of our community coalitions, as well as faith-based programs are represented in some of our community coalitions, and they're really intended to be a coalition of the willing, of people that are interested in and willing to focus very intently on trying to develop strategies to help reduce opioid-related overdose deaths within their community. And in some places, they build on existing coalitions, and in other communities, they've brought people together and created them from scratch. There are some key positions that you see on this slide that we think are very central to the work that we've been doing in the Healing Community Study. The first is that community engagement facilitator, and that individual serves as a liaison between study staff and the coalition, and they're really trying to keep things going and moving forward and be a real centralizing force for the coalition. Then we have media and communication champions that are often volunteers from within the coalition and the community, who are people that may or may not necessarily be involved in communications or media themselves. And they've helped to both facilitate the development of our communications campaigns as well as the dissemination of materials. Data champions are really important because, as you'll hear, the CTH intervention is not only community engaged, but also data driven. And so local data champions play a super important role, and they are often members of the community that come from public health departments, for example, or other people from counties that have some important role involved in data. And they both facilitate providing data to the study, but also in determining what data resources are available within the communities that go into community dashboards that I'll mention later, that provide communities the ability to have visualizations and have data related to different aspects of things that are going on in the space of opioid use disorder, treatment, services, as well as overdose. Then we have someone that's involved in dashboards, both in the development of the dashboards, the ongoing training of people to understand how to use those dashboards. The dashboards include both process as well as outcome data for each community so that they can understand what's happening within their community context on many outcome variables, but also how they're doing in the process of implementing their particular strategy for addressing these issues. And then we have implementation specialists for the evidence-based practices. And these people are really key because they help coordinate and facilitate the selection of evidence-based practices for a community-targeted response strategy, but also the implementation of those within different organizations across the community. So the study, even though it says there's 6 phases, there's really 7, because we start with phase 0. Phase 0 is a preparatory phase that really involves behind-the-scenes work that the research sites are involved in collaboration with our data coordinating center and NIDA, where we're trying to do a landscape analysis in order to understand who's in the community, who are people that might be involved in a coalition. Are there existing coalitions? Can we augment and strengthen them or bring people together around the table to participate in a coalition focused on this particular issue? Also, to look at the strengths and gaps in terms of the provision of services and the availability of evidence-based practices in communities, and to begin thinking about and preparing for our communications campaign and thinking about some of those other key roles that I mentioned on my previous slide. And then getting started is all about establishing a community coalition and training them. There's a lot of training that's been developed across the Healing Communities Study for coalition members, everything from stigma and sort of unintentional stigmatizing language that people might be using, to how to use data and understand data that's going to be provided through the study, to a lot of training around the evidence-based practices and the research behind those. And we begin sort of an introduction and an overview of all of the different phases that we'll be working with coalitions through. And then getting organized is really about having an in-depth review of the evidence-based practices, developing a shared vision and understanding, and beginning to refine and think about launching the very first communications campaign. In phase 3, the study has found a template and a way to put together very detailed community profiles for communities, and that data also goes into the dashboards that are provided to communities as well. And these profiles are really fundamental in understanding what's happening, not only with regard to the overdose crisis that's occurring in your communities, but as I said earlier, into understanding what organizations within your communities are providing what kinds of services, where do you have gaps, where do you have bounty? So maybe in your particular community, you'll be provided with data that will let you know that you've got a lot of spaces and a lot of availability in your treatment program. So treatment capacity is not an issue for you, but getting people linked and into those treatment programs is essential. Whereas another community might find out that they've got really long waiting lists for people to get into methadone treatment or on buprenorphine, and in those instances building capacity becomes really important, so that you can think about in phase 4 you're really developing your community action plan. So you're looking at the menu of evidence-based practices, you're looking at your dashboard and community profile, and you're really sitting down and developing that plan of what types of strategies are important for our community, who will we partner with, or who will we approach about partnering with, and how will we go about moving those things forward. And in phase 5, you're actually implementing and then monitoring how well you're doing at implementing that action plan, with some ongoing feedback from your data dashboard, so that you have the opportunity to have some rapid learning cycles and go back and tweak your response strategy or your community partnerships to try to have maximum impact. And along the way, you're launching communications campaigns. And then we built sustainability planning in from the very beginning, even from phase 0. And a part of that was because as I've been a part of NIH science for many years, we unfortunately have the experience sometimes of funding research that does really powerful and impactful things. And then as soon as the funding goes away, then those interventions go away. And we did not want that to happen in this particular instance, where if we had significant reductions in overdose deaths, the last thing we wanted when the study ended was for all of the support and all the services to end, and so for those to climb back up again. So sustainability planning with the community coalitions and with the states is built in from the very beginning, because you had to bring state partners to the table as a part of this study as well. And building that response strategy and doing that community planning involves really thinking about sustainability and how can those interventions be sustained. And we have timed this out in a way where there are unprecedented dollars available to many of our communities through the opioid settlement funds. And I'm really proud to say that we're working across the states and across the communities with the opioid settlement funds. And in many instances, they're being used to sustain a lot of the great programs that we establish. So the second part of the intervention is the ORCA, and I'm going to spend a little bit of time talking about that. It's a menu of evidence-based practices that very importantly have evidence supporting their ability to reduce overdose death. There's a lot of interventions in the substance use space that have evidence, including primary school-based prevention. But yielding return on primary school-based prevention on doing something like reducing overdose deaths by 40% takes a long time, a lot longer than we had within the Healing Community Study. And so we really had to focus then on those interventions that identify and take those people that are at highest risk of an overdose and a fatality, and be able to think about what are those particular evidence-based practices. And so our menu has 3 areas. The first is on increasing overdose education and naloxone distribution, or OEND. The second is on enhancing delivery for medications for opioid use disorder, or MOUD. And the third is on continuing to improve prescription opioid safety. And all of these menus come with implementation strategies and technical assistance guides and all kinds of hours of training that have been developed by all 4 of our sites. So I'm going to give you a little bit of a sample of what the menu looks like. So you can see here that we go across the entire continuum from primary prevention of not using opioids, which is not really the space that we were in the Healing Community Study, all the way out to sustained recovery. So we really start with more secondary prevention, with identifying people that are at risk for whatever reason, and then following them all the way through to whether or not they're at high risk because they're using but may not have an opioid use disorder, or do they actually have an opioid use disorder? Could they benefit from medication? Are they continuing to be engaged in care? Are they being retained in care? And then are they sustaining long-term recovery within the community? And within each of the 3 menus that I spoke of that you can see here, there's like a drop down that comes out that opens up so that you can see that there are different areas, submenus, and under those submenus are many different implementation strategies. And I'm going to use the OEND menu as an example. So you see under menu 1, the OEND menu, that it drops down into 2 submenus, OEND for at-risk venues, and then naloxone availability and overdose hotspots. At-risk venues and at-risk individuals are those people that are at the highest risk of having an overdose. An at-risk individual would be someone that has had a prior overdose. We know that they are at increased risk of having another and having a fatal overdose. A high-risk venue is, for example, medication withdrawal facility that helps people to withdraw from opioids, but may not send them out the door on any type of MOUD. And so when they go out, they've lost their tolerance, they're very vulnerable. If they return to using again with lost tolerance, they're at a super high risk. So that's an example of an at-risk person, an at-risk venue that we would target, that communities would consider targeting as a part of their OEND selection. And then availability in overdose hotspots is just simply that. It's geocoding where overdoses are occurring within communities and trying to saturate them with naloxone. Under effective delivery of MOUD, we had a couple of submenus expanding availability of MOUD, but then also really importantly in engaging and retaining people in treatment. You can have a lot of people coming into treatment, but if you're not keeping them in treatment, you're not retaining them, then over time, you're really not going to have a lot of gains on curbing overdose fatalities. And then safer prescribing included safer opioid prescribing for pain, as well as prescription take-back programs. So if you look under the OEND menu specifically, as I indicated, it opens up even more where there are even more strategies. So active OEND was where we had efforts where people were going intentionally to place naloxone in the hands of people that might use it, whether that is a local community member that might see someone who is overdosed and used it, or whether it is a person who is still involved in using drugs, or whether it is a family member, or whether it is an EMS worker. So actually developing interventions that would get OEND into the hands of at-risk individuals in their social networks, get OEND in the hands of everyone who is in a high-risk venue. And then passive OEND was optional for communities to choose, and that involved OEND by referral. So that was things like ensuring people knew about how they could go to the pharmacy and be able to get naloxone at a pharmacy, as an example. And then naloxone administration was another optional set of menus where it was increasing the capacity of first responders to administer naloxone, and mostly to leave leave naloxone after someone had overdosed. So it's one thing if you go and you administer naloxone, and if they don't go to the hospital, then the ability to be able to leave naloxone there for individuals to have available to them if they or anyone in that household ever experienced an overdose. So that gives you a little taste of what the menus look like in the implementation strategies. And then the third component is the public health communications campaigns. We had 3 different topics: naloxone, MOUD, and staying on MOUD. And the campaigns were intended to increase the adoption of evidence-based practices, reduce stigma, drive demand for evidence-based practices. And the targets were really community-wide, but some targets like providers, community leaders, people with lived experience. We developed over 6,000 communications campaign materials for our wave 1. So in wave 2, those numbers are going up. And all of the examples that you see on this slide are actual community members that volunteered to have their pictures taken. And in some instances, their stories told about, you see the one on the far right, I'm a devoted father, waiter, a coach, and I also take buprenorphine. Or I'm a father, I'm a new hope, I'm a community leader, I take buprenorphine as a part of my recovery. We have adapted them to several languages. So we have a lot of diversity of the faces and the places and the languages that you'll see within our communications campaign materials. We have materials that we've used in social media. We have print materials. We've done everything from billboards to coffee sleeves to the side of buses. In addition to that, providing communities with a toolkit for how they could write op-eds for local newspapers, have radio spots so that they could do what's free media opportunities and leverage those as well, in addition to the fact that some of these, of course, come with an expense. So I'm going to talk for a minute about some of the things that we've done. We've completed our intervention in wave 1, as I said, and we've completed our comparison period between wave 1 and wave 2, and we're in the process of finishing the collection of our data and analyzing our data. We've done a lot of different simulation modeling, and York has been very involved in using modeling both to inform their community-based interventions as well as to look at things at a more state and nationwide level. We navigated the COVID-19 pandemic, which was not an easy thing because we were just getting going with this intervention and with our wave 1 communities when COVID hit and shut the world down. So people quickly pivoted to an online presence and being able to meet and work together online. And we really had to ask the NIH for additional time for this study because we were trying to get into places like hospital emergency departments and community jails and homeless shelters and different places that you couldn't get into those venues to be able to work with individuals around anything outside of COVID because everybody was so overwhelmed. But we made it through that. We are intervening in wave 2 now, and we are working on some dissemination products, including 2 practice guides that are being funded by SAMHSA. What I'm really impressed with, though, and this is just for wave 1, is all of the hard work that all the communities have done. In wave 1, our communities selected 718 evidence-based practice strategies. 317 of those were implemented for OEND, 309 for MOUD, and 92 for safer prescribing. We have also done over 6,000 hours of training and technical assistance in wave 1 for over 20,000 people. We've developed an extensive data infrastructure. 66 communities received a data dashboard that I was talking about earlier. We have 52 different administrative data sets that feed into the study, data like Medicaid data, EMS data, hospital data. All of these data owned by someone else, and being able to figure out how to have that data flow and how to work with the owners of the data has been a huge learning curve for all of us. And we're really proud to be able to have that much administrative data across such a wide variety of sources. We've got data that also comes from the DEA and IQVIA and just lots and lots of rich data sources. We have done in-depth community descriptions of resources and gaps. That's that landscape analysis I was talking to, and we've done over 1,300 qualitative interviews to date, and we'll be doing more. We've completed 5 communications campaigns in wave 1 and developed over 6,000 different products. And we've demonstrated that when it comes to naloxone, we could, through our communications campaigns, reduce the stigma around naloxone and change attitudes and behaviors, including having people being more willing to carry naloxone after being exposed to the communications campaign. We've published a lot of things, and we're continuing to publish a lot of things, and you can see some of the topics. And in implementing those evidence-based practices, another thing that's really impressive about this study is in wave 1, again, we partnered with 278 healthcare organizations, 231 behavioral healthcare organizations, and 163 justice organizations. So we've figured out how to implement evidence-based practices in communities where uptake has been low, and we've figured out how to do it across different venues where uptake has been low. So we have a lot of things that we've collectively learned how to do, and a lot of hard work has gone into this. We're also collaborating with state opioid abatement efforts in being able to use those funds. And we've developed a big data infrastructure. 2 of our states, Kentucky and Ohio, have decided that they are going to take the data dashboards and they're going to be supported out of the governor's offices in those 2 states, and they're going to make them available statewide for every county in those communities. people who participated in the study have been successful in getting other NIH grants for other work. New York created solutions to reduce lags in death data, which has been no small feat for you all. You have got people on the study, Nabila, James, and others that have worked really tirelessly to try to help improve the quality and the timeliness of really important data that you all have, whether it's Medicaid data or whether it's death data. And that's going to help the state with every type of health condition, not just opioid use or overdose. And we've prompted Medicaid providers in states to look at and try to improve quality, particularly on race and ethnicity. We discovered that the quality of data related to race, ethnicity, and the completeness of that data just across our 4 sites was widely variable. And if you want to really know anything at all about health equity and who's getting what types of interventions and whether or not things are being made available, you absolutely have to collect these data, and you have to do it in a meaningful and in a harmonized way. We've increased collaboration to capture better health equity data. We've developed better methods for calculating the prevalence of opioid use disorder, because we know there's lots of shortfalls to the household survey-based approach that's supported out of SAMHSA. And we've developed, and again, New York's led the way, agent-based models for communities to use in deploying resources. So I'm going to go over a few examples real quickly and then wind up. So this is an example from the state of New York, where this is a little bit of their menu 1 in action, right? So one of the things that happened in a lot of the communities is that they decided to use geo-targeting to determine where to place naloxone boxes. And so they placed 629 naloxone boxes in wave 1 communities using geocoding data for high need areas, provides 24/7 access. No waiver training or ID is required. They placed them in a lot of different important locations like commuter train stations, parking lots, motels, restaurants, and retail stores. And you can see there, as of the date that they sent this, the number of units that had been distributed. Now, those numbers will have gone up since then because they've been used. One of the sustainability strategies that they implemented was who and how they were going to refill those boxes. In Kentucky, they figured out how to better develop a peer support and recovery coach workforce. And they were able to do that across healthcare, across the legal system and social services. They placed 28 peers in 44 different agencies with 8 additional peers that were dedicated to OEND only. And you can see here some numbers about the number of clients that these peers were able to link to MOUD, about the numbers of people they contacted, about those that they've been able to retain in treatment, about the recovery support phone calls, about the miles they've driven in supporting people and participating in medication for opioid use disorder, and about smart recovery meetings, because unfortunately, there are 12-step programs across the country, and in the state of Kentucky in particular, they have an issue where they don't support people being in 12-step programs if they're on medication for opioid use disorder. So smart recovery offers an alternative, and so they really leaned heavily into that. In Ohio, they used their faith-based communities in wave 1, and they used those for the distribution of OEND as well as MOUD and a communications campaign. It was particularly important within the African American communities that the faith-based communities got involved to help deal with all of the very legitimate fear and concern that exists within communities of color, of healthcare providers, and of research and science. As well as dealing with stigma around things like naloxone or being on medication. And then finally in Massachusetts, they developed medication consult services in hospitals in these 5 of their 8 wave 1 communities, where they were able to increase the number of people that were initiated on MOUD. and refer them then on to methadone treatment programs or other providers in the community. They used recovery coaches, and they really catalyzed the culture of those hospitals and those providers to help them really understand OUD and MOUD. We have learned a lot so far, and I'm just going to do a high-level walk through 5 lessons. We've learned that to really get people to address health equity and diversity, you have to be very proactive. It takes a gentle approach with communities to do this, but hoping that they will take it up on their own doesn't always happen. It does in some instances, but not always. And so if you consistently want it to happen, you really have to build it into your community engagement process. And I'm really pleased to say that in Wave 2, we have done that. We have followed the leadership of New York because they did a lot of that work in their Wave 1 communities. We've learned that it's very challenging to implement MOUD for a lot of reasons. There's regulatory issues around the medications. There's provider issues around it. There's payment and reimbursement concerns, and there's a lot of stigma. So when you're trying to implement MOUD, it takes very targeted strategies, a lot of work, and it just takes time. We've also learned the importance of addressing social determinants of health, including housing, food, and especially transportation. When we started the study, there was this myth that transportation was a bigger issue in rural than urban communities. It's an issue in all our communities. It doesn't matter whether they're rural or urban, because often the services are far from where the people that we're trying to serve actually exist. So we have developed many different transportation models, and I'm looking forward someday to seeing those different models being tested to see what are the strongest evidence-based approaches to that. We've learned how to use all these different diverse administrative data sets and systems, and we learned how to be more efficient in our intervention. So our Wave 2 communities are really receiving an improved intervention because we've taken all of our lessons learned and we've poured them back into adapting that particular intervention and making it better. This is just 3 sample publications. We have a special issue in drug and alcohol dependence focused on the study that covers a lot of what I've covered, but in a whole lot of depth. We did a study early on that looked at disparities in trends by race, ethnicity of overdose fatalities. And then there was another study that looked at the impact that COVID was having on people's willingness to go to emergency departments following an overdose. And we've got many more things that are coming. So that's it. I'm gonna stop sharing and turn it back over to.
And I'm always amazed how you can describe this complex study with multi-layers and so many investigators in a very short period of time. I always listen to you and learn how to present in a very short period of time. So we have approximately 15 minutes for questions and answers, and we have received a few questions previously, and we received a few now. I want to start with a question that we received now, and I'll start with it, which the question is how we are incorporating harm reduction into the approaches and strategies we use. You gave one example of the Nalox boxes and other issues. What other harm reduction approaches we're using in the healing community study?
So menu 1 is really all about harm reduction, and it's about getting naloxone and overdose education out into communities. And there's a wide range of ways that's happened. Nalox boxes, some people have set up vending machines, and those vending machines include naloxone, but also have included other harm reduction items, including syringes, fentanyl test strips, which in the beginning of the study, we weren't really able to use. That switched later on. You see the use of naloxone, Nalox boxes, the vending machines, handing out naloxone at different events, leave behind programs where someone from the community who has the data will go and very discreetly leave behind naloxone to households where overdoses have occurred. A lot of the geo-targeting efforts, And we work with syringe service programs, and in those syringe service programs, we provide naloxone and partner with them. I think another harm reduction approach is we meet people where they are. We're not trying to force any individual who has living experience into any particular kind of intervention. Our goal is to help them to continue living and to live for another day, so that hopefully they can get into some good treatment at a point in time when they're ready. We've done a lot of stigma reduction, which nobody really talks about as harm reduction, but I think is huge in the harm reduction space as well. The communications campaigns that support naloxone and are intended to reduce stigma are really another harm reduction sort of approach that we've included. We have an ancillary study that we're supporting now looking at fentanyl test strips as well, and fentanyl test strips is definitely a harm reduction approach too.
Thank you very much. And another question is, what did you learn from the implementation of the Healing Communities Study in Wave 1 that you are doing differently in Wave 2?
Oh gosh, so much. So we learned that the pace of a research study and the pace of a community are not the same thing, and I'll explain that in a minute. If you're in a research study, you know, you've got to deal with the tension between internal validity of the study and external validity of the study. And so because we're across 4 states, we had to have everybody go through all of those phases of community engagement in lockstep, right? So there was a window of time, a number of weeks. You were doing phase 1 and then phase 2 and then phase 3. Well, some communities were so ready to go and so anxious, they wanted to go from phase 1 all the way to phase 4. And so in Wave 2, they go with the pace they go. We don't have to keep everybody together now. And so we're allowing all of the communities to be able to progress in the intervention. So we're much more efficient than we were before. We learned a lot also about how to include equity and a focus on health equity and a focus on diversity within the intervention. And we built that into the intervention. So in each phase in the community engagement process, as well as within the data, we are including more data, more of an intervention component around that. As I said earlier, though, one of the unfortunate things for us is we're limited when it comes to data, because so much of the health data that we collect in this country doesn't do a good job of having that race, ethnicity component, which I mean, I'll say it, I've said it before, I consider that to be a part of structural racism. If you don't see the problem and know the problem, then you can ignore the problem and you don't try to fix the problem. But we've learned a lot about how to do and how to address that. So I'd say we're more efficient, we're excited about that, and we're excited about having a greater focus on health equity.
Thank you very much. Another question is, can you elaborate on the content and impact of anti-stigma communication campaigns?
So the communications campaigns, there's not a campaign that says stigma. The campaigns and the way that they've been intended to address stigma are through those stories. So you saw some of the examples when you saw community members that were there and their story was obvious. Those were print materials, but we also have videos and we have audio recordings where people are telling their story in a way to talk about the, for example, one woman in one of our communities, not in New York, tells a story. She's actually got a very influential position within community government, and she had an opioid use disorder, and naloxone was used on her on 6 different occasions before she was able to get into and sustain recovery and begin rebuilding her life. And so her telling that story in that community is an example of dealing with stigma. There's another mom in one of the communities that I'm thinking of that has done a video that they use in that community and in that state around the power of naloxone and the importance of carrying naloxone. She had 2 sons that were 2 years apart, and they both died of an opioid-related overdose. Then we have great stories of people that have used MOUD either as a part of their journey, or they've stayed on it for years, because some people do. They stay on medication for many, many years. It's no different than if you stay on medication for your diabetes or your hypertension in that way. And so it's the stories of the lives of these individuals and the power of that that's really intended to work against stigma. There's a lot of training that's been done, and New York and Columbia has done quite a bit of training for community members and coalitions actually around stigma too. So we've got a lot of training resources available through the study.
Thank you. Another question about dissemination. How do you plan to disseminate the Healing Community Study? What will you disseminate first? Who will disseminate the intervention? Do you have ideas?
I have more ideas than I have time to execute them. We partner with SAMHSA, and they have provided some funding. And so those will be probably the 2 first things that are going to go out, because we're already working on that with them. And they're going to disseminate through the TTCs, the Technical Assistance and Training Centers. And so one product is going to be focused on the community engagement process, all the way from coalition creation to the different phases and types of activities that we engaged in, with examples from the sites. And then another set of products is going to focus on the ORCA. It's going to be a little bit more of a high-level overview of the ORCA. So that's 2 pieces from the intervention. Then we're fortunate that recently the NIH funded a dissemination center called the HEAL Dissemination Center. And we were the first HEAL study out the gate. So we're the first HEAL study that's got things ready to disseminate. And so they're coming to us first. And the woman that is leading up the development and dissemination for the OUD and overdose space is someone I've known for many years, and she's fantastic. And so we're working very actively on a list, on a whole set of things that will be disseminated. Everything from, she's wanting to stand up academies and training programs, to lots of different things around the ORCA menu. She wants to do something on the dashboards, including the coding that we developed, that's open source coding for the data dashboards. So we've got a lot of things that are going to be happening in that particular space. I'm very, very excited about that. I'm really, really pushing and working toward that, because I think it's really, really important. I think we've got a lot of things that communities and organizations are gonna really find helpful.
I truly appreciate your vision, Redonna, from the first day. You're saying, think about dissemination. Even in the CTH, you're in fact reinforced that the issue of dissemination could be integrated in phase 0 to phase 6. And now your leadership role with really SAMHSA and others to help us to disseminate fast the model is amazing. So I really appreciate it. We have time for another question, and will be our last question. The question is, what did you do in rural area to improve access to medication for opioid use disorder or other interventions?
It depended on the community. If you've seen one rural community, you've seen one rural community. And there's a lot of stereotypes and myths that I think we all carry about the capacity of rural communities. Some of our rural communities had some pretty good capacity already, and others didn't. So it just really depended. So a couple of things that we did. Well, we were helped by the loosening of regulatory issues around telehealth with the COVID pandemic, because some rural communities were able to lean very heavily into telehealth and an expansion of telehealth in a way that didn't exist prior to COVID. So that definitely was something that we used. Some communities purchased community health vans, and those vans travel around the community and they provide services to individuals. In some instances, they purchased a vehicle to be able to take people to treatment, to transport them actually around to different treatment programs. And in some places, you know, they worked really hard with their providers to see if they had providers that were already prescribing buprenorphine, or if they weren't already prescribing buprenorphine, could they get them trained? At that time, you had to have a waiver. You don't have to now. And could we provide them with the support and the technical assistance that they needed to be able to start prescribing? And so that worked as well. It's hard in the amount of time we're with communities to stand up a methadone program from start to finish. But we did have some expansion efforts that took place within communities. So if there was a methadone treatment program, let's say in the county next door, and the community that was in the study didn't have one, maybe they worked with that methadone treatment program to develop a satellite. We did that. So they would put a satellite program within the community that was a part of the Healing Community Study to be able to increase capacity there as well. Housing is a big challenge in rural communities, and having affordable recovery housing that allows you to have your medication for opioid use disorder, that's a big challenge. And being able to come up with ways to, because if you don't have housing capacity, it takes a while to build that. So that's been a hard one, I think.
Yeah. Thank you very much, Dr. Chandler, for your presentation, for taking the time to present where you are so busy. I know you're around the clock on Zooms, and to be available and present, I truly appreciate it. We have more questions which I will share with you. We don't have time to answer it, but I want to let people know that there is a presentation on April 25th from 5 to 6. We'll be talking about data approach to implementing evidence-based intervention in the Healing Community Study, and we'll be talking about agent-based modeling. And the beauty of this coming presentation will bringing the community to counties to talk about how they use agent-based modeling in delivering their interventions. So will be a debate between the scientists and the community. I'm looking forward to these presentations. So please put it in your calendar for April 25th from 5 to 6. And again, thank you, Dr. Chandler, for your time and energy and contribution in this study. So see you.
Thank you all for inviting me. It was a pleasure to be here. And thank you all, everyone in New York that's been a part of this journey. I really cannot tell you how much I appreciate all your dedication and hard work, because it's because of you that this has come to life. So.